Okay, for this section, we're going to be going over audiogram interpretation from Chapter 7. So our objectives are to describe the parameters of an audiogram and explain why dB hearing level, dBHL, is used for audiograms, identify from ANSI standards the corresponding calibration reference values for different transducers, convert among dBHL, dBSPL, and dBSL, that is dB sensation level. It's probably a new one. Identify unmasked and masked air conduction and bone conduction thresholds for each ear from symbols on the audiogram. Explain and use 3 different ways to record pure tone thresholds. Other objectives include understanding why and when using masking for the non-test ear would be needed for both air conduction and bone conduction testing. Know how to apply common terminology for describing degree, type, and shape or configuration of hearing losses. Describe a variety of audiograms using appropriate terms relative to type, degree, and shape of hearing loss. Recognize audiograms that show thresholds at the limits of the equipment, tactile, vibrotactile responses, or collapsed canals. And calculate a pure tone average from the audiometric thresholds. First, we want to show you just a regular audiogram. This is a blank audiogram. Don't worry about the ANSI standard listed on the side there. It doesn't change much over the years. This audiogram just happens to be from an older ANSI standard, but like I said, the ANSI standard really doesn't change much over the years. It's very minimal changes. And for our purposes here, it's not going to have any impact whatsoever. So the key thing is the aspect ratio of the audiogram is you might say regulated. The aspect ratio of the audiogram should be 20 decibels on the y-axis for every octave on the x-axis. So the distance between 0 to 20 dB on the x-axis should be the same distance as 250 to 500 hertz on the distance between 0 to 20 dB on the y-axis should be the same as the distance between 250 to 500 hertz on the x-axis. So 20 dB per octave is the ratio that you want for an audiogram. The x-axis is frequency, 250 to 8,000 hertz. We often test inner octaves, which have tick markers on them at 3,000 and 6,000 hertz, but they just don't have the label of 3,000 and 6,000, but they are often tested. 125 hertz is usually tested when there is some low frequency hearing loss is present with a severe to mid-high frequency hearing loss. It is not commonly or routinely tested, but it is occasionally tested. Testing above 8,000 hertz up to 16,000 or 20,000 hertz would be called an extended high frequency audiogram, and you would have an extended graph or a different graph that would show that. That's roughly beyond the scope of the lecture today. So we document the patient's pure tone thresholds on the audiogram. We use the audiogram to document hearing test results. That would be the patient's pure tone thresholds. We use the audiogram to understand the patient's hearing abilities to facilitate rehabilitation or rehabilitation planning. So as I mentioned, decibels hearing loss is on the y-axis. Associated with intensity of sound. It is not intensity, well, it is intensity of sound, but it's converted to dBHL with the lowest levels on the top and the highest levels on the bottom. That's the opposite to what you would expect on most scientific graphs, but it is historical legacy that has it set up that way, and it is set up that way everywhere. Units of intensity of decibels hearing level are different from units of dB sound pressure level that you learned about in acoustics class. There is a very convenient relationship between the two, but there is not a one-to-one relationship between the two. But there is a very simple conversion factor to convert between the two. On the horizontal graph, 0 dBHL represents the intensity level at the required to achieve the detection threshold for the average normal hearing person. 0 dBHL corresponds to a particular dB sound pressure level value that varies with frequency. So 0 dBHL corresponds to a certain dB-SPL level, but that dB-SPL level is going to vary depending on the exact frequency that we're talking about. So it's like the threshold of audibility scale in dB-SPL is normalized to create a flat line for normal hearing on the dBHL scale. The benefit of the dBHL scale is that 0 dB is normal for all frequencies, so that thresholds greater than 0 dBHL are equal to that amount of hearing loss in dB. Here are the conversion factors. So the conversion factors are called retspools and retfuls. Retspools being reference equivalent threshold sound pressure levels. Those are used for air conduction transducers. And then retfuls, reference equivalent threshold force levels, which are used for bone conduction transducers. So here on this graph, let's look at standard frequencies here for a moment. Standard frequencies. We've got supraoral and we've got insert and circumoral. These are all using retspools, and they're all different values because different transducers have different retspool values, and they have different retspool values depending on the frequency. Heck, you can even see supraoral headphones, depending on the model, have different retspool values. They're close, but they're not identical. And then you can see that insert earphones, it's really the same retspool value. The insert earphone models available are all the same duplicates of one another, so they have the same retspool values regardless. Circumoral headphones are the same way. The two main models available have the same retspool values. And then we have for bone conduction transducers, two of those bone conduction transducers, they have the same retfull values. This is the sound pressure level that you would add in order to the dBHL value to create the dB-SPL value. So you would add this to 0 to create the 0 dBHL, or so let me rephrase that a different way. So say you had a bone conduction threshold at 42.5 dB force level relative to 1 micronewton. That would equal 0 dBHL. Or over here a little bit more clearly, say we had a TDH39 headphone, 1000 hertz, and our threshold was 7 dB-SPL. That is the same as 0 dBHL. If I go down here to a DD45 headphone at 2000 hertz, where it says 8 dB-SPL, that's the same as 0 dBHL. And then we also have extended high frequency range here, going from 8 to 16,000 hertz up here. And this is for extended high frequency testing. So audiometric 0 is for all of these. dB-SPL is referenced to 20 micropascals. I think you learned that in acoustics class, that dB-SPL has an inherent reference of 20 micropascals. Bone conduction has a inherent reference of 1 micronewton. So with retspools, with retfulls, conversion of dB-HL to SPL, we simply add the reference ANSI value to go from HL to SPL, and going from SPL to HL, we subtract the relevant ANSI value. So simple addition and subtraction. Yes, you can use logs to prove them, but when we're talking about logs, you can simply add and subtract these values in order to go from dB-HL to dB-SPL, just simple math. So now talking about decibels, hearing level, converting between dB-HL and dB-SPL, again, simply involves adding or subtracting the retspool or the retfull. dB-HL plus retspool or retfull equals dB-SPL, or dB-HL is dB-SPL minus the retspool or the retfull. The conversion between these different references is especially useful within dispensing audiology, because when we do an audiogram, we're usually talking about dBHL. When we're working with hearing aids, we're talking about dBSPL. May also be useful for demonstrating the relationship between environmental sounds and hearing thresholds. So if you have a chart that shows noise levels that are of intensity level that require hearing protection, that are dangerous levels, those are going to be dBSPL charts usually. Here's what we can see if we're talking about hearing aid audiology. We've got a speech map from a VeriFit. So VeriFit being a hearing aid verification unit using real ear measures. Here on this graph, on the left side, we're plotting it on dBHL like an audiogram. We have a 50 dBHL thresholds across the board. And down here at the dotted line, it's 0 dBHL normal hearing thresholds. But this patient has left ear 50 dBHL thresholds. Up here, these asterisks represent the average loudness discomfort levels. Now, if we were to convert this to dBSPL, there's two things that would change on this graph here. One, you would see the curve would no longer be completely flat anymore because we saw that the Retzpel values varied depending on frequency. So now our curve is not flat precisely anymore. The other thing that changes when we talk about dBSPL on a hearing aid verification unit is the y-axis gets flipped upside down. 0's at the bottom and 140 is at the top. We also see normal hearing threshold levels. This is the normal intensity contour for hearing threshold levels. It's not a flat line anymore because we're talking about dBSPL. And that just has to do with the ANSI conversion factors. Here's an example of documentation of hearing thresholds, just air conduction hearing thresholds. The X's being for the left ear, the circles being for the right ear. If we're color coding them, which is optional, but if we're color coding them, red is for right, that would be the circles, and then left is blue, and that is for the X's. Symbols used are those recommended by ASHA, but symbols used may vary depending on the part of the world you're in. Like if you're in the UK, it's governed by the British Society of Audiology. You may use different symbols for different purposes. So just be aware that it is not universal. This is for the United States, these symbols. Now, after we obtain the air conduction thresholds, we need to obtain bone conduction thresholds. So now you can see here, bone conduction thresholds are not typically connected by lines, but the way air conduction thresholds are. Now, they can be in some softwares, but they're not strictly, they don't have to be connected by lines. If they are connected by lines, they're usually dashed lines. Notice that the right unmasked bone conduction threshold is placed to the left of the vertical line, and the left unmasked bone conduction threshold is placed to the right of the vertical line. So when you're facing the patient head on, the right bone conduction symbol lines up with the patient's right ear, and the left bone conduction symbol lines up with the patient's left ear. So if we look here on these bone conduction symbols over here, right unmasked, if you're looking at the patient, that's the right ear. Left unmasked, if you're looking at the patient, that's like a headphone on their left ear. That's where those symbols come from. So in this particular case, we don't have any significant air bone gaps between air conduction and bone conduction, so masking is not needed in this situation. Here's a different example. Here's an example where we have air conduction, the circles for right ear, air conduction thresholds are better than air conduction thresholds for the left ear, the X's. We can see a gap between the two. Now what we have here is right unmasked bone conduction thresholds, which line up with the right air conduction thresholds. But then we see that we have left masked bone conduction thresholds. We know that here by the symbol here. Left masked bone conduction thresholds line up with the left air conduction thresholds here. And the reason we have masked thresholds is because we had a gap of greater than 10 dB between the bone conduction thresholds of the unmasked ear and the air conduction threshold of the test ear. We'll get into more of that shortly, but the purpose of me showing you this right now is to show you different ways that thresholds can be documented. We've got a single panel here. We've got the left and right ears on the same audiogram. We also have the option of a two-panel format where we have the thresholds are broken out into left and right audiograms. The right audiogram on the left side and the left audiogram on the right side. That is one convention which you can use with computer software. A lot of times it'll like with my software that I use, it defaults to the two-panel mode, and then I automatically switch it to the single panel mode when I'm done testing so I can see it all together. But it's sometimes more convenient to have it in the two-panel mode when you're comparing to previous audiograms. When you have a line showing a previous audiogram, that's helpful to have a two-panel mode. But then when you're comparing to each other, it's helpful to have a single panel mode. You have a third way you can present audiometric data. You have tabular information here. So in this way, you're looking at it strictly in numerical format in a tabular chart. This is mainly used by the VA. I'm not a big fan of that, but I didn't work at the VA for very long. I never got really used to seeing audiograms in tabular form, but the VA absolutely uses audiograms data in tabular form. I'm sure once you get used to it, it becomes a little bit more familiar. Now let's take a closer look at the audiometric symbols here. We zoomed in here. So we can see we've got air conduction unmasked, which is a circle for the right ear, the X for the left ear. Air conduction masked, which is the triangle for the right ear, the square for the left ear. Bone conduction unmasked, which is this less than symbol for the right ear and the greater than symbol for the left ear. And then the brackets for the bone conduction masked, left bracket for the right ear, the right bracket for the left ear. Again, for bone conduction, imagine that you're looking at the patient with the headphones on. Their right ear has the right headphone on the left side. Their left ear has the left headphone on your right side. So it's the way that you're looking at them for the bone conduction symbols. Their right ear, their left ear, because of how you're looking at them. And then we've got the no response symbol. This is attached to a symbol. So the arrow going down in the opposite direction of the ear being tested. So the right ear, say we had a right ear, Say we had a right ear no response for air conduction. The circle would have the arrow going down attached with an arrow going down to the left for the right ear. If it was a left ear, air conduction no response, you'd have an X with the arrow going down to the right. Same thing with the bone conduction mass symbols here. So the bone conduction mass symbol for the right ear, say it was no response at the limits of the audiometer, you would have the arrow attached to it going down to the left. And then here, the no response symbol for the left ear, the arrow would be attached going down to the right. Then you also have the S, which is the sound field response. This is going to be mainly if you're doing VRA, visual reinforcement audiometry in pediatrics between 6 months and 2 years of age, and you can't use headphones because the patient won't tolerate headphones. You may use an S to represent sound field responses, which are not ear specific. So we need to recognize the need for when we need to mask. We've talked about masking briefly. We need to know when we need to mask. That's the key thing, because we need to obtain ear-specific results. There are situations when sound is presented to the test ear. In this example here, sound is being presented to the test ear, the left ear, but is heard by the non-test ear, as we see by this diagram. Both the test ear and the non-test ear are hearing that signal. Bone conduction testing is the best example of this. So what if non-test ear has better hearing than the test ear air conduction? when you're performing bone conduction testing. So let's take a look at this here. We see two audiograms on the left and the right. We know the patient has sensorineural hearing loss in the right ear from the left audiogram. We see that there's the air conduction thresholds from the circles and the masked bone conduction thresholds for the right ear. They line up, indicating a sensorineural hearing loss in the right ear. We know they have pretty normal hearing in that left ear. We see that the left ear X's for air conduction line up with the unmasked bone conduction thresholds in the left ear. But what if the right ear bone conduction thresholds were not obtained with clinical masking to the left ear? Then we would see the audiogram on the right side. We would see unmasked right bone conduction and unmasked left bone conduction would all line up with the better hearing ear, because we need clinical masking to distract the non-test ear to make sure we can get accurate bone conduction thresholds for the test ear. That's the key here. If we don't clinically mask, we'll get something like this on the right side, which is inaccurate, versus something on the left side, which is accurate. So masking must be presented to the non-test ear. This is called clinical masking. For clinical masking, noise is presented to the non-test ear is called the masker, and the thresholds obtained are referred to as masked thresholds. We have air conduction, narrowband noise in the non-test ear. The bone-conducted signal is not heard by the non-test ear due to the masking to the non-test ear, and then bone-conducted sound is heard by the test ear. That's the ideal scenario for bone conduction masking, which is by far the most common type of masking. So here we go back to the chart where we see that bone conduction masking has not been presented to the left ear, and we have erroneous right ear unmasked bone conduction thresholds that match up with the left ear. So this is what if the right ear bone conduction thresholds were not obtained with clinical masking to the left ear. If masking was not applied to the left ear for right ear bone conduction, then we see a false air bone gap for the right ear. That is, bone conduction thresholds appear to be better than they actually are. So masking is crucial to obtain ear-specific data under certain circumstances. So what are those circumstances? So recognizing the need for masking with bone conduction. So if we look at bone conduction and air conduction here separately, we can see that we have a bone conduction. We have a 30 dB HL signal presented to the test ear, shown in this person's left ear here, and we see that interoral attenuation is 0. So that means that the stimulation getting to the non-test ear is 30 minus 0, so 30 dB HL gets to the non-test ear. So we need masking in this situation when our test signal exceeds our interoral attenuation. Over here, for supraoral headphones, air conduction here, our signal being presented to the test ear is in the right ear is 80 dB HL. Our interoral attenuation is 40 dB, so 80 minus 40, 40 dB HL is getting to the non-test ear. We need masking in that situation, most likely. So air conduction testing requires masking under some situations as well. For air conduction stimulation, high intensities can vibrate the skull, thus sending signals to the non-test ear, but it is not as common as bone conduction masking. Here's an example of right ear air conduction thresholds obtained without masking and then again with masking. So why are the unmasked air conduction thresholds in the right ear better than the masked air conduction thresholds in the right ear? So the question is, why are the, again, let me repeat that again. The question is, why are the unmasked air conduction thresholds, I'm sorry, we don't have air conduction thresholds in the right ear that are unmasked. So why are the unmasked air conduction thresholds in the left ear here, why are they better than the masked air conduction thresholds in the right ear? It's because we applied clinical masking in that situation. What I meant to say was, why do we need masked right ear air conduction thresholds in this situation? The general rule of thumb for masking for air conduction thresholds with supraoral headphones is that if we have a difference between the non-test ear and the test ear greater than 40 dB, or between the unmasked bone conduction threshold and the test ear greater than 40 dB. So if we see these circles here and we compare those to the X's, we can see the circle is 50 here, and we see it's 10 here. That's a 40 dB difference at 1000 hertz. We need to mask for air conduction now. If we see the difference between 50 versus 5, that's a 45 dB difference at 500 hertz. We need to mask for air conduction. The difference between 50 versus 0 is 50. That's greater than 40, so we need to mask for air conduction. So when we mask for air conduction, we're applying clinical masking noise by air conduction to the non-test ear, the left ear. So we need to mask in this situation for both air conduction for the right ear and for bone conduction for the right ear. We mask for bone conduction for the right ear because we see there's a difference between the air conduction threshold in the right ear, even at 50 here, between air conduction threshold and the unmasked threshold is greater than 10 dB. That's why we mask for bone conduction. And we need to mask for air conduction because the difference between the air conduction thresholds unmasked in the right ear versus the air conduction thresholds in the non-test ear, the left ear, and the other rule between the air conduction thresholds in the test ear and the unmasked bone conduction thresholds, that's greater than 40 dB. So for those two reasons, we need to mask in the right ear. So for both air conduction in the right ear, we need to mask, and for bone conduction in the right ear, we need to mask. So these are the minimum intraoral attenuation values for masking. So if you have 0 dB is the minimum intraoral attenuation for bone conduction testing. In the real world, it might be 5 to 10 dB in the real world for high frequencies, but theoretically it's 0 dB, and these will often vary depending on the frequency, but we usually use one single number. For both supraoral earphones and circumoral earphones, the minimum intraoral attenuation value is 40 dB. So if we have a 40 dB difference between air conduction thresholds or between air conduction threshold of the test ear and the unmasked bone conduction threshold of the non-test ear, then we need to mask. And then for insert earphones, it's a little bit larger. I've seen numbers as low as 50 dB, as high as 60 dB. I'm going to adopt 55 dB for our purposes here, but you might see different numbers. It's definitely not higher than 55 dB. That's on the high end. If you see a number higher than that, they're talking about a mean, not a minimum. And the minimum is what's important, not the mean. So when we describe audiograms, we want to talk about the degree of hearing loss, the type of hearing loss, the shape of hearing loss. Use brief sentences to describe hearing in each ear. The reader should be able to imagine the audiogram with reasonable accuracy. Excessive detail is not necessary, and it's probably excessive. I agree with this. These are the degrees of hearing loss levels that we typically use in the United States. The key thing here is that you see between 16 to 25 dB HL. That range is interpreted differently between adults and children. Less hearing loss, so for 16 to 25 dB, that's normal in adults, but it's slight hearing loss or minimal hearing loss for children. That has to do with the larger educational impact on children as they rapidly are developing speech and language and their demands in the educational environment. The relationship between degree of hearing loss and functional abilities or self-perceived hearing handicap is a tenuous one. It's common to describe an audiogram's degree of loss over a certain frequency range. For example, mild sloping to moderate sensorineural hearing loss. I'm not a huge fan of using descriptors that span more than two ranges. My preferred method, which is not universally accepted, my preferred method is to take a 4-frequency pure tone average at 500, 1000, 2000, and 4000 hertz, and take the average of those 4 frequencies and use that to describe the hearing loss. That is a method that's been somewhat adopted by the World Health Organization. They have a slight variation on it where they talk about it in the better hearing ear, and they use different categories, but they use a 4-frequency pure tone average to describe the loss. I'm an outlier in describing it that way. It's more common for people to say mild sloping to moderately severe, but I'm just not a fan of that method. I don't think it's as helpful. Here on an audiogram, we can see those same degrees of hearing loss. So for an adult, normal hearing between 0 to 20. We showed 0 to 25 before. There's not universal acceptance on this. Mild hearing loss going up to 40. Moderate hearing loss going up to 55. Moderately severe hearing loss going up to 70. And severe going up to 90. Profound being 91 and greater. So with sensorineural hearing loss, we have the same loss for air conduction as bone conduction. For conductive loss, we have an air-bone gap. Normal hearing for bone conduction and poor hearing for air conduction, and then mixed is a combination of those two. And we can see that outlined in the graph here. So does the loss include the conductive and or sensorineural portions of the auditory pathway? If it includes the conductive only pathway, it's a conductive loss. So if air conduction thresholds are normal, then the bone conduction thresholds are elevated, it's a conductive loss. If sensorineural hearing loss, if air conduction thresholds are abnormal and bone conduction thresholds are equally abnormal, it's a sensorineural loss. If we have air conduction thresholds and bone conduction thresholds are both abnormal, but bone conduction thresholds are significantly worse than air conduction thresholds, that is a mixed loss. Here are types of losses here. Again, air-bone gap. For sensorineural, air-bone gaps are less than or equal to 10 dB. For conductive losses, air-bone gaps are greater than or equal to 10 dB. For mixed losses, air-bone gaps are greater than or equal to 10 dB, and bone conduction is worse than 25 dBHL. So that's one way you can think about it. We can see these rules fall into place here with these audiograms. Sensorineural hearing loss, we have air-bone gap less than 10 dB, but bone conduction thresholds are worse than 25 dB across the board. Conductive loss, we have air-bone gaps are greater than 10 dB, but bone conduction thresholds are normal. Mixed hearing loss here, we have air-bone gaps are greater than 10 dB, and bone conduction thresholds are greater than 25 dB. Sometimes we may have a conductive loss in one section of the audiogram and a sensorineural loss in another portion of the audiogram, so you want to describe both. You might say you have a sensorineural hearing loss with a conductive component if it's not quite a mixed hearing loss. If there's only one or two thresholds that have a conductive component, but it's predominantly sensorineural, you might call it sensorineural with conductive components. Now we'll talk about the shapes of hearing loss. I want to mention those significant characteristics across the test frequency range. Is it sloping, mild in the low frequencies to moderate in the high frequencies? Is it flat with only small variations as a function of frequency? Is it bilateral, same across both ears? That would be symmetrical if it's the same across both ears, or bilateral, present in both ears, but not necessarily the same across both ears. Bilateral, if you're symmetrical, you are bilateral. If you're bilateral, you're not necessarily symmetrical. You could be asymmetrical, which is also bilateral. So these are some audiometric configuration labels. Bilateral, meaning that the results are, well, this isn't true. Symmetrical means the results are similar in both ears. Bilateral just means there's a hearing loss in both ears. So that's a little bit off there. Relatively flat, within 20 dB across the audiogram. Sloping, greater than 20 dB per octave towards the high frequencies. Precipitous is a steeply sloping audiogram, greater than 40 dB per octave as far as the drop. Rising, improving from low to high frequencies. You might also call that a reverse sloping audiogram. Or notched, you might have just a notched region of hearing loss in the 3,000 or 6,000 hertz range. And then a corner audiogram where we have residual hearing only in the low frequencies, like 125 to 250 hertz. And then we have a lot worse hearing above that. Here's some examples of audiograms. We have relatively flat on the left side. We can notice that it's within 20 dB across the audiogram. So it goes downward a little bit from 40 at the lows to 55 in the highs, but it's all within 20 dB. We call that relatively flat. Sloping, we have a greater than 20 dB octave change going from 50 at 500 to 60 at 1000. That's only a 10 dB change. 60 at 1000 to 70 at 2000. It's only a 10 dB change. 2000 is 70, and then 4000 is 80, only a 10 dB change. So this is not greater than 20 dB per octave, like it says, but this would still be called a sloping audiogram. Rising audiogram, or a reverse sloping audiogram, improving from the low frequencies to the high frequencies. Pretty clear cut, reverse slope or rising audiogram. Either descriptor is fine. Then here's that corner audiogram I was talking about, where you have very little hearing loss at all, very little hearing, lots of hearing loss, very little hearing, predominantly in the low frequencies. You would call that a corner audiogram. This is the situation where you might test 125 hertz. Here's a precipitously sloping hearing loss. Let's see what kind of drop we have with this precipitously sloping hearing loss. Going from 25 dB at 250 down to 80 dB at 4000. This is greater than 40 dB per octave in this one frequency range. So that is correct to call that a precipitously sloping audiogram, where you have a single drop that's greater than 40 dB per octave. And then you have a notched audiogram here. In this case, it's at 4000 hertz. The notch is usually at 3000, 4000, or 6000 hertz, where you have a notch and then you have recovery. That's oftentimes from noise exposure, not exclusively from noise exposure, but oftentimes from noise exposure. Here are just some shapes of the different audiograms for you to remember. Flat, sloping, rising, noise notched, U-shaped, which we haven't talked about really. Another term for that is cookie bite. That's what I prefer. It looks like you took a big bite out of a cookie. Reversed or U-shaped is the same as a trough-shaped audiogram. Then a high-frequency audiogram is where it's normal in the lows but sloping in the highs. You might call that a high-frequency audiogram. And there are other patterns that don't fit any description very well. Here's some other shapes here. Sloping audiogram for the right ear, flat audiogram for the right ear, rising audiogram for the left ear. We have normal hearing in the left ear here, and they're unilateral. And then we have a fairly flat audiogram for the right ear here under unilateral. So what shapes are these here? We'd probably call the one on the left side a high frequency loss, because we have normal hearing in the lows and it slopes down in the high frequencies. But you wouldn't be counted off if you called that a sloping audiogram. That would be okay too, but probably a high frequency loss. And then on the right side here, you'd probably call that a flat audiogram. You'd have to call that a flat audiogram. That's the definition of a flat audiogram. What shape are these? Here on the far left side, I would call that a cookie bite audiogram or a U-shaped audiogram. That's oftentimes seen with genetic hearing loss, not exclusively, but usually with genetic hearing loss. And then here we've got a gently sloping hearing loss here in the middle. And then we've got a relatively flat audiogram here on the far right because everything is within 20 dB. So some sample audiograms with descriptions here. Here, two possible descriptions we have. One, we could say pure tone threshold testing indicated a moderate conductive hearing loss through 2000 hertz, rising to normal in the high frequencies for the left ear. Hearing loss was within normal limits for the right ear. I think that's overly verbose in my opinion. This is an opinion. Left ear showed a moderate conductive hearing loss through 2000 hertz. I think that's a better description, personally. I think being brief is better than being overly verbose. Here's another one. Here's two possible descriptors. Pure tone threshold testing for the left ear indicated a sensorineural hearing loss that was mild at 1000 hertz, sloping to moderate in the high frequencies. The right ear showed a sloping sensorineural hearing loss that was mild at 250, sloping to severe at 8000 hertz. I'm not a fan of that descriptor. I prefer the second descriptor. The left ear has a mild to moderate high frequency sensorineural hearing loss through 500 hertz, sloping to severe at 8000 hertz. Honestly, I don't like that descriptor either. I would take the 4-frequency pure tone average of both of these and describe them that way. That's what I would do personally. But there's a lot of different user preference in how you describe an audiogram, and I'm the outlier, so I don't want to tell you to do it my way when my way is not the most common way. Some descriptors here. Pure tone threshold testing indicated a moderate to moderately severe sloping sensorineural hearing loss in the right ear. The left ear showed a severe, relatively flat, mixed hearing loss through 2000 hertz with a 40 dB airbone gap at 250 to 15 dB airbone gap at 2000, rising to a moderately severe sensorineural hearing loss in the higher frequencies. Well, that is a mouthful. I wouldn't use that one. The other one here is the right ear has a sloping sensorineural hearing loss that ranges from moderate in the low frequencies to moderately severe in the mid to high frequencies. The left ear has a severe to flat hearing loss with a conductive airbone gap or airbone component from 250 to 2000 hertz. Let me tell you how I would describe this because I'm getting tired of these descriptors that I feel like are overly verbose. I would probably call this a right ear, moderately severe, gently sloping sensorineural hearing loss, and a left ear, rising, severe mixed hearing loss. That's probably what I would say if I was describing the audiogram. I would keep it far more simple than these descriptors. But that's just my opinion. I think it's a little bit better to differentiate audiograms, to do it that way. But that's my opinion, not the book's opinion. We go back to the way the book is describing the audiograms in a conventional way to describe them. We would say the pure tone threshold testing indicates a relatively flat, moderately severe hearing loss in the right ear, which was mixed with 30 dB airbone gaps through 1000 hertz and sensorineural from 2000 to 8000 hertz. The left ear has normal hearing through 1000 hertz with a sensorineural hearing loss that precipitously slopes to severe at 4000 hertz and profound at 8000 hertz. Not a fan, personally. Or we could say the right ear has a moderately severe mixed hearing loss through 1000 hertz and a moderately severe sensorineural hearing loss in the high frequencies. The left ear has a moderate to profound sensorineural hearing loss from 2000 to 8000 hertz. Again, I think that's a little overly verbose, personally. So if it was me, how I would describe this audiogram is I would call it a moderately severe mixed flat hearing loss in the right ear and a mild high frequency sloping mild high frequency sloping sensorineural hearing loss in the left ear. That's probably what I would describe it as, a little bit less verbose than the descriptors from the textbook. So what happens when the upper limits of the audiometer are reached and there's no response from a patient? Now you want to affix those downward facing arrows. So here we can see we've got, in the right ear, we've got air conduction thresholds here and that are normal. In the left ear, we have masked air conduction thresholds for the left ear that are either in the profound hearing loss range in the low frequencies, or they have arrows attached in the mid to high frequencies, indicating there's no response. We can also see left masked bone conduction with arrows attached going the opposite direction, indicating no response. So that's what you want to do when you reach the limits of the audiometer and you get no response. You use the no response key and you indicate that with the arrows. So is there an air bone gap in the right ear? Unknown. We don't know if there's an air bone gap in the right ear because we reach the limits of the response for the bone conduction audiometer and we reach the limits of the response for the air conduction audiometer. The only way to venture a guess if there's an air bone gap in that right ear is to do tympanometry and see if the middle ear is normal or abnormal. Even that doesn't tell you if there's an air bone gap, but it can give you some idea if you do middle ear assessment with tympanometry. So these are the output limits with different types of headphones. I think I mentioned before that the supraoral headphones had a little bit higher output limit than the inserts, and the bone conduction vibrator had a significantly lower limit for output limits. This is based on a GSI 61 audiometer, so it's a generation old compared to the GSI AudioStar Pro. And the bone vibrator here is the B71, so this is the older bone conduction vibrator here. And the supraoral headphone was a TDH model. I don't remember if it was a TDH 49 maybe. And the inserts are an ER3A style insert. The insert doesn't matter that much. So you can see first comparing supraoral and inserts, there's not a huge difference between the two, but if you have somebody with a profound hearing loss, you do get a little bit greater output, especially at 8K for the supraoral headphone. And it doesn't usually matter for most patients, the difference between 110 and 120. But at 8K, that can be a little bit of a meaningful difference. The biggest thing that you notice is the bone conduction vibrator output is way lower. But remember, we also have vibrotactile thresholds to contend with at low frequencies. So at 250 hertz, a lot of times these patients at 50 dB are feeling the response rather than hearing the response. So here's some examples of this is a severe hearing loss or even a severe to profound hearing loss with supraoral headphones. The question is, are these low frequency responses due to auditory responses or tactile responses? Most often they occur at 250 hertz, as low as 25 dBHL. Secondly, at 500 hertz, as low as 55 dBHL. You can ask the patient if they felt or heard the response, but they're probably not going to be reliable. There's been a study that looked at the reliability of patients being able to differentiate the two, and they often can't differentiate the two. They often will tell you they felt the response, but whether they felt it or heard it, it's really hard to say. We can be pretty confident in this case that they felt the response, unless the tympanogram was abnormal. Here's an example of collapsed canals, which is far more common with supraoral headphones. In an elderly population, you might have supraoral headphones collapsing canals up to a third of the time. In just a general clinical population, it's more like 4 to 5% of the time. So that's the drawback of supraoral headphones in elderly adults. We can see we've got an air bone gap in the high frequencies. And the easiest way that you would know that this is an air bone gap in the high frequencies from collapsed canals would be the way the canals look when you visualize them, and also if you compared it to insert earphone testing. In an ENT clinic, a fast-paced setting, you may not always have time to compare it to insert testing. So inserts may be the way to go in general, as long as they fit well for elderly patients. Or circumaural headphones don't have nearly as high of a degree of collapsed canals. They can have collapsed canals, but not nearly as often. So circumaural headphones or inserts are usually the way to go with an elderly population. So talking about pure tone averages, we want to use air conduction thresholds to summarize the effects of hearing loss on speech understanding. We have a traditional pure tone average, which is 500, 1000, 2000 hertz. That's what we're comparing to our speech recognition threshold. We have a 4-frequency pure tone average, 5, 1, 2, and 4. That's what I use to describe the audiogram personally. That's what the WHO uses to describe the audiogram, but it is not the standard that everyone uses. We have a high-frequency pure tone average, 1000, 2000, 3000, 4000 hertz. That's mainly used by the VA. We have a 2-frequency pure tone average, 500 and 1000 hertz. We use that to compare it to a speech recognition threshold when we have a steeply sloping audiogram, when we have pretty normal hearing thresholds at 5 and 1, but abnormal at 2000. Some of these are used for calculations for hearing handicap and compensation purposes, like the 5, 1, 2, and 5. Like the 1, 2, 3, and 4 high frequency pure tone average. That's used for VA compensation purposes. Now I do want to talk briefly about decibel sensation level. So when we talk about dBSL, we're talking about what sensation level that the individual patient is hearing the threshold at. So if a patient has a threshold at 60 dBHL, they have a 0 dB sensation level because it's 0 dB above their threshold. If they have a threshold at 60 dBHL and you present it at 70 dBHL, they have a 10 dB sensation level. If they have a threshold at 60 dBHL and you present it at 90 dBHL, they have a 30 dB sensation level. The unit of dBSL is used to set presentation levels for some speech and central auditory processing tests. Take a look at a few more audiograms here. We have a normal hearing in the lows to a sloping hearing, high-frequency hearing loss in the highs. For that woman, that's probably just age-related hearing loss. We have this guy who has a history of noise exposure with that deep notch at 4000 hertz. We would probably call that a high-frequency notched audiogram. And then we've got this kiddo who has a cough, and he probably has an upper respiratory tract infection, bilateral, flat, mild conductive hearing loss. He probably has bilateral otitis media. Here's another audiogram to take a look at here. We have got pretty normal hearing in the right ear for the most part, except when it goes into 6000 and 8000 hertz, it drops down. I would call that a normal hearing loss, normal to slight hearing loss. Probably a slight hearing loss is what I would call that, because it's so normal for the majority of the frequency range. It's going to have minimal impact on the person's auditory function. In contrast, that left ear is going to have a more significant impact. To me, that would look like a, let me calculate that. I would probably call that left ear a moderate sloping to moderately severe sensorineural hearing loss. So this is certainly either you might call it a unilateral hearing loss, or you might call it an asymmetrical hearing loss, depending on how you classify that right ear. Now, to me, it looks like they've masked a little excessively for air conduction in this patient. Like, for example, they've masked for air conduction at 250 hertz. That really wasn't necessary to do. But in this case, in the same thing at 500 hertz, that wasn't really necessary to mask for air conduction in the left ear at that frequency. Just at a couple of frequencies here. I'm not sure why this audiogram did that, but that's all I've got on this lecture here, and I'll upload this to YouTube for audiogram interpretation. I lied. I've got one more slide here. Here's another one that I want to go over here. Here's another audiogram in the right ear. We've got normal hearing in this left ear. This is an unusual configuration. This is one that we don't see as often. You might call that a cookie bite audiogram, but it does take on an unusual configuration. normal hearing at the low frequencies, and then reverse sloping in the high frequencies. I would probably call that a cookie bite audiogram. As far as degree of hearing loss goes, if I was taking the 4-frequency pure tone average for that left ear, I would probably call that a moderate cookie bite hearing loss. Now, we don't know if it's sensory neural or not. I'm assuming it's sensory neural, but we don't know if it's sensory neural because we don't have bone conduction thresholds there. So bear that in mind. And then lastly here, we've got the audiogram with the bone conduction thresholds. So now we know for a fact that that left ear is sensory neural. So a moderate cookie bite hearing loss in that left ear, sensory neural, and then normal hearing thresholds in the right ear. Now that's all I've got on this lecture here, and I'll upload this to YouTube.